Thank you. Uh, uh, Distress management in oncology patient. Distress, according to the International Psychological Association, is the sixth vital sign and needs to be taken in every patient. Now, I don't have any conflicts of interest. I'm not going to deal with all aspect of distress. What I'm going to show is what work was done by me or my colleague in my previous institute and in Tata Memorial Hospital to capture distress and to provide solutions which can be useful in developing world. Now, the reason is we always take anything which comes from the West as the standard of care. Food, clothing, and stay is the basic need. We differ from the West in all these aspects, but still we think in medicine anything which happens in the West is easily applicable to India. It doesn't happen that way. We need to find our own solutions which would lead us to go up to that standard, but we need to have our own solutions which would help us in doing the achieving this. Now, doing in most of the scenarios in India, the OPDs are overcrowded, the doctor to patient ratio is low, the nurses to patient ratio is less, and most of the academic centers don't have a dedicated psycho-oncologist which sits with the physicians, or there is not even a dedicated psycho-oncologist on each floor of every hospital. Now, in that scenario, how can we talk about doing distress screening? Because if you do a distress screening, it's a screening. If the patient has high distress, it needs to be addressed. How would we go about that? So I would capture this in these 4 points. Is it feasible to do distress screening in India? What is the incidence and factors which tell us how much distress is there? Does it have impact? And what are the solutions which we can have in our setting? This is a feasibility study of distress screening which I did in Malabar Cancer Center. It's a regional cancer center in north of Kerala, and it was led by Dr. Sampada Desai. Now, we wanted to use IPO as standard for Malabar Cancer Center, wanted to introduce distress as the sixth uh, vital sign. The issue was the doctor to patient ratio was very on the lower side. Now, would it be feasible to do distress screening regularly in OPD aspect for every day? So, what we decided that we would do a pilot run for 1 day. The incentive given to the clinicians was they would get an authorship in this publication, and the more the number of patients they screen, they would get the higher the authorship in this publication. The second thing which was told was we would do distress screening between 9 o'clock to 4 o'clock. Obviously, it would delay the OPD. Every patient who comes after 4 o'clock won't be, we will be doing the distress screening. The hypothesis we set was that if greater than 90% of our population of patients which attend the routine OPD, we could do a distress screening, then we would suggest that it is feasible to do distress screening in a routinely running heavy OPD in an academic cancer center. We use the distress NCCN distress thermometer for helping the patients. This is in Kerala, so the local language is Malayalam. So the distress word was translated into Vipatti, Sikam, which are the common words which tells you about distress. And this is the way we followed. We didn't have a dedicated psycho-oncologist with us, so we tied up with a private center in which a psychologist agreed to see all the patients who had high distress without any cost for this study. What it came to us that we could screen only 84% of our patients for distress. The interesting point was nearly 30 to 40% of the patients had distress, but only 10% of these patients, in spite of making travel arrangements, fixing the appointment with the psycho-oncologist, reached the psycho-oncologist. The average time taken for screening itself was 5 minutes, and we felt that we need to do something more. We sent this recommendation to the Kerala government, and after that the government was happy to give us a psycho-oncologist to that center. We also started work on doing translation of the distress thermometer, so at least the time which is taken by the physician to take the distress score, that the patient could self-administer himself. Now, what is the incidence of distress in India? This was a study with Malabar, which should see that even in patients who are treated, even with the patients who are treated on follow-up, around 15 to 20% of these patients have distress. Patients who have treated in palliative setting, they obviously have a higher distress, which amounts to about 80% of the cases. We did a similar study in head and neck cancer who underwent palliative chemotherapy in Tata Memorial Hospital. These were 200 consecutive patients who were treated with metronomic chemotherapy. And what we saw was in these patients, after counseling them about the poor prognosis, we saw that the incidence of distress was 44.5%. And as it was head and neck cancer, we could see that the practical problems led to 66.5% of the distress. Physical problems, which is common in most of the patients have oral cancers, that was around 71.5% of the distress. Now, we couldn't find any factors which predicted or not predicted for having high distress. Now, we also did a similar study in patients who were curative, who were undergoing radical CTRT. This is unpublished at present, it is sent for publication. We saw that nearly 56.7% of our patients have high distress. Now, and we found some factors. What I'm trying to convey here is that there is not a single factor which can easily predict that whether the patient has a distress or doesn't have a distress. Whether in curative setting, whether in palliative setting, whether in follow-up, or whether this patient is on treatment, that there is a good proportion of patients who are distressed. So it's important that we screen patients at baseline at every important time points for the distress. Now, we also did this distress work in patients who, I do also through neuro-oncology, in patients who are taking adjuvant temozolomide. So it's just a once a month visit with these patients. And to our surprise, in these patients also, we saw that nearly 62% of these patients had high distress. Now, did this impact outcomes? Now, in the radical CTRT study, we did saw that patients who had high distress, their outcomes were poor. We couldn't confirm this in the palliative setting, and I'll let you know why we couldn't confirm that their outcomes with respect to compliance or with respect to the time to event outcomes were poor. There was an innovative way of, we used the way to select the patients out and to resolve their distress. We'll come to that solution. When we did the study in Malabar, we saw that very few of the patients, in spite of taking an appointment with psycho-oncologist, actually visit the psycho-oncologist, and that apprehension about whether a new person could actually solve their queries which the treating physician could be, they thought would be better and able to solve. And hence, when we did the study in TMH in a palliative setting, what we did is, the problems which we identified on problem list, the treating physician itself talked to the patients about these problems, tried to provide solutions inside the OPD itself. Obviously, it took time. Each patient used to take around 20 to 25 minutes, but this discussion leads to a lot amount of decrement in the psychosocial distress of these patients. We also saw that irrespective of what kind of problems the patients had, practical problems, family problems, emotional, spiritual, psychological, a good 15 to 20 minutes discussion done by the clinician itself is able to get this distress down. And if you have a look here, at baseline, nearly 44.5%, so 89 patients had distress. After the physician counseled, 36 patients only had high distress. And when these patients who had high distress in spite of physician counseling were counseled by psycho-oncologist, only 8 patients the distress was there. And this is the reason why in the palliative setting we couldn't see that the high distress at baseline impacted compliance or outcomes, because post-physician counseling and post-psycho-oncologist counseling, most of the patients' distress was resolved, and it was unlikely that this would impact any of those important figures. We did the same thing in neuro-onc patients also, and what it shows is that median time for the counseling which it took was nearly 30 minutes, and post-counseling, nearly in all patients this distress can get solved. Most of the patients have distress regarding to knowing about the prognosis, or how the finances can be arranged, how the social worker could work them up with the places which nearby where they can stay and take treatment at our places. And if we at least in our experience saw that if you provide solutions for these problems, most of the patients' distress gets resolved. Just to way forward, what's happening at my old institute, I just saw this when I contacted these researchers there. They have already done a translation of the distress thermometer in Malayalam, and they have validated the self-administration of this distress thermometer, and they are going ahead with the future studies with this. The work which I showed was funded from intramural grants from Malabar Cancer Center and from Tata Memorial Hospital. I need to acknowledge my colleagues, Dr. Kumar, Dr. Vanita, and Dr. Amit, who have worked with me, Dr. Joyita and Dr. Goswami, who had worked in the studies in TMH. These were the colleagues with me in my previous institutes, Dr. Desai, Dr. Biji, Dr. Shirley, and Dr. Shantam, who worked with Malabar Cancer Center with me, and a lot of residents who are now my colleagues and my consultants along with me, who worked with me in the distress thermometer study in palliative setting. Thank you.